I'm Jerry Young, born in '38, so I'm 72 years old. I think most people take their voices for granted. You know, I can talk, see, hear, and I took it for granted like everybody else. Then when I got hoarse, that situation started to change. I got hoarse after a routine endoscopy. I called my doctor. She said, if it doesn't go away, see an ENT specialist. It didn't. I did. It was confirmed that I had throat cancer. What's called squamous cell carcinoma, which is the common type of cancer that people that have oral head and neck cancer have squamous cell carcinoma. The data said that 90% of people like me, their cancer was killed with radiation. Considering the statistics, it was a no-brainer. I do radiation. And 28 sessions later, I still had cancer. So surgery is the next best way to go for me. I received what's called a partial laryngectomy. This surgery I didn't know at the time, but it's rarely done, mainly because a lot of surgeons, ENT, ear, nose, and throat specialists, whatever the reason, they don't learn the procedure, don't want to learn the procedure. It does take time, a lot more time than just going in and cutting out your larynx and dropping it in the wastebasket. The procedure he performed, he took out the front cartilage. That is taken out, so he had full access to the larynx. He then cut out both vocal cords. He then took the vocal cord cartilage and stretched that and attached it to another structure in the voice box. Then that is sutured shut. Close up that cap, and that's it. The vocal cord cartilage is now trying to function as vocal cords and making a sound, so although I still have the same mannerisms, characteristics, the speech pattern to my voice, the way I talked, I have a different voice. Most of us that have had oral head and neck cancer, we have what I call a new normalcy. I said, will I ever have a normal voice? Anatomically, it's impossible, right? Because I no longer have vocal cords. That's it in a nutshell. I think the biggest limitation is socially. I don't have any volume to my voice. My wife loves it because I can't yell at her. I've heard a few comments from her say, hey, you got a sexy voice. And I like that, of course. That's good for my ego, but it is what it is. Several months after my surgery, I started attending a laryngectomy group, and I was the only guy in there without a prosthetic in my throat. And none of those people had ever heard of the kind of surgery I had. They thought I still had vocal cords, and I said, no. I had a supracricoid laryngectomy. One day during an appointment with Dr. Damrose, I said, Dr. Damrose, how many of those guys in this group would have been candidates for the partial laryngectomy that you performed on me? And I expected an answer like, 10%, 50%. His answer was 50%. I said, you're kidding. Half? What in the world's going on? And he very honestly said, well, a lot of the guys, a lot of physicians don't know how to do it. Some maybe don't want to learn. You feel sorry because most of us don't do our homework when it comes to finding out we have a problem, a medical problem, and then we put our faith in our doctors. What it did was really kind of anger me. It made me want to do something. This word needs to get out. Hopefully through what happens here, maybe some other laryngology surgeons will understand that they may need to get a little bit up to date, learn a little bit more about what they can do for patients. Thanks to Dr. Damrose, I have a voice.
The primary symptoms of obstructive sleep apnea are daytime sleepiness, loud, disruptive snoring, and witnessed breathing pauses, They can also have secondary symptoms such as a dry mouth and throat upon awakening, night sweats, and morning headaches. Obstructive sleep apnea is very common. It affects about 25% of men between the ages of 30 and 60, and about 10% of women in that same age range. Above the age of 60, it's thought to be even higher in prevalence. There's three main treatment options for obstructive sleep apnea. The first main treatment is continuous positive airway pressure, or CPAP. That's basically a mask that fits over the nose, connected by a hose to an air pump. The air pump brings in outside room air, gently pushes it into the nose and down the airway and prevents it from collapsing. That's the most common form of treatment. There's also surgical options to actually improve the structures of the airway to allow more air passage. And thirdly, there's oral appliances, which basically are mouth guards that go into the mouth that either move the tongue forward or the lower jaw forward and allow more space for the upper airway as well. There really is no way to actually prevent sleep apnea because a lot of it is determined by heredity. But one thing that people could do is try and keep their body weight low, just because it has been associated with obstructive sleep apnea. So increased weight predisposes you to sleep apnea. The reason why treating obstructive sleep apnea is important is it can have profound impact on the cardiovascular system. So it can affect the heart as well as predispose the person to high blood pressure. In addition, there's evidence that also indicate that the person can have problems with the functioning of their brain. So it's very important to have this disorder diagnosed and treated.
I'm 80. I'll be 81 in May. I've always been extremely independent, and I enjoy life. I have non-Hodgkin's lymphoma, and I've had 2 episodes. I have a lot of little tiny tumors in my chest associated with the lymphoma, and one of those little tumors looked more suspect than the others. It was suggested that I have a needle biopsy, and I elected to just have them watch this little spot. I first found out that I had lung cancer when I went to see Dr. Gilbert Chu, who was my oncologist. And he said, "Bonnie, the spot that we have been watching looks pretty suspicious, and I have been consulting with Dr. Schrager." And he explained that they wanted to do this new procedure with this thoracic scope. He explained to me that it was a very delicate procedure, and that if he was able to use this instrument, the surgery would be much less invasive and my recovery would be faster. If he couldn't use it, then he would have to go into a more detailed procedure and spread my ribs and so on, and that my recovery would be longer. Fortunately, he was able to use the new procedure, and my recovery was very speedy. I was out of the hospital in 3 days. I think the fact that I've had 2 different kinds of cancer, and the first kind twice and then the lung cancer, has made me more aware that it's important to take care of myself as best I can, enjoy life while I can. I think that it's better to have a positive attitude and assume that you're going to be all right, and that's what I try to do.
My name is Michael McConnell. I'm the acting director of the Preventive Cardiology Clinic. My specialty is cardiology. One thing that does happen as a cardiologist is I'll be on a plane flight somewhere and the person next door, we start talking about what I do and what they do. Of course, when they hear I'm a cardiologist, it immediately shifts to what can I do about heart disease and isn't it all in your genes? Well, it really turns out that 80% of heart disease, particularly coronary artery disease that leads to heart attacks, is preventable. As a cardiologist, I certainly feel like I have to practice what I preach. The most important thing that I try to do is trying to watch what I eat. And a few years ago, my weight was creeping up and my cholesterol numbers were creeping up, and I got more diligent about watching what I ate. limiting portions, and was able to get my cholesterol numbers better and keep my weight in a better range. As far as favorite heart-healthy food for me, my wife makes a great salad niçoise, so it has a lot of good vegetables and tuna, and it's really one of my favorites, with a little glass of wine. Fitting exercise into a busy schedule is always a challenge. I'd like to exercise every day, but that doesn't happen. I usually get out about 3 times a week. As far as the type of exercise that I do, I've gravitated over the last several years to trying to vary between running and biking and swimming. But to be honest, any kind of exercise is good, anything that gets your heartbeat going and your blood flowing. What I try to emphasize is that you really do have a lot of control yourself over your own health. And certainly as cardiologists, we're there to help you and guide you, and if needed, to give you medications or other procedures to help your heart. But I really try and stress that it's not all in your genes, and you have an active role to play yourself.
We installed the pneumatic tube system back in '91. There's about 4 miles of pneumatic tubing in the system, and if you calculate how many people it would take to hand carry those products, it would be a lot more than the few people I have to manage the system. We do approximately 7,000 transactions a day. There's approximately 123 to 129 stations, which covers Blake Wilbur Cancer Center, Lucille Packard Children's Hospital, and Stanford Hospital and Clinics. The longest trip would be from Boswell, blood draw in A101, over to Blake Wilbur. We send things from blood to medicine, specimens. A lot of testing is really dependent upon the tube system. If you go in with an ailment, they have to draw blood, they do all their testing, but that blood takes off in the tube, gets to a place where they have to do some testing of the blood, and then the results sent back to the doctor. So when they see this tube come in with a special number and a buzzer, oh, that's ED, they run, get the carrier, they get it in the system, and then therefore the results can get over to the clinician faster. We're in the process of trying to visualize what happens when the pneumatic tube takes off in the system. We're going to be putting a light and a camera inside this carrier, and we're going to send it off and see what type of video we get out of this. Okay, here we go. What we're doing is sending it back to ourselves. We're watching the travel of the carrier. It's going up, it's going to the penthouse right now through this path here. When it passes this transfer unit, now it's at the top level. Now here it comes, coming back. Taking this path back to this station, which is 555.
You're like a proud papa with a new baby.
Am I holding it incorrectly? It's pretty cool. Oh, it's pretty clear. The way it sits now, it's like perfect.
Parkinson's disease affects a group of cells in a part of the brain called the substantia nigra. Those cells produce a neurotransmitter, a communication chemical in the brain called dopamine. For whatever reason, and we still don't know most of the reasons, those brain cells die. When enough of those brain cells die, people begin to have symptoms, and those symptoms can include things like tremor, which is shaking, slowness of movement, rigidity, problems with walking, problems with speech, and many others. Risk factors for Parkinson's disease are being studied even as we speak. It's clear that there are some genetic components as well as some environmental components. Environmental factors can include things like pesticides, jet fuel, other types of toxins like metals, but it's still unclear as to what precise environmental factors may cause it or contribute to its development. Parkinson's disease occurs mainly among older people. The age of onset is usually somewhere between 50 and 60 years old, but it can affect all age ranges. It can affect younger people as well. There's even a juvenile form of Parkinson's disease. There's not a particular predilection for any one race or sex. Early signs of Parkinson's are very subtle, and it's often misdiagnosed early on. It can be anything from a slight decrease in the swinging of an arm, a little bit of clumsiness, a trip in your step or gait. It starts on one side more than the other. So Parkinson's is rarely the same on both sides of the body. Usually what happens is that someone will go along for a year or two with symptoms like this and then finally get referred to a neurologist who will diagnose the Parkinson's disease. Most patients within a year or two of their first onset of symptoms will have noticeable symptoms of Parkinson's disease, and most are started on medication at that point. Medicine is really the cornerstone of treatment for Parkinson's disease. Replacing that missing dopamine is really what treatment is all about. There's now a very sophisticated array of medicines that can be used. Eventually, though, all of those medicines will fail, and the patients will get side effects, and then we really need to start thinking about other types of therapy. Deep brain stimulation is an operation that was approved by the FDA in the United States in 2001 for the treatment of tremor, and then in 2004 for the treatment of Parkinson's disease. Things that we can help with deep brain stimulation surgery are speed of movement, fluidity of movement, often walking or gait, decrease in tremor. Things that we can't help are things like speech problems, which unfortunately don't get better with surgery, cognitive difficulty, which many patients do have, and those things can often get worse after surgery. In terms of new therapies, we're constantly looking for new ways to treat Parkinson's patients and other patients with degenerative diseases. Some of those ways can include gene therapy, which means that we are changing the genetics of individual brain cells. We're looking at new targets for deep brain stimulation. There are some things that deep brain stimulation just doesn't work very well for in the standard target. And obviously, with Stanford's prominence in stem cell research, we're looking towards translating many of those stem cell revolutions that are happening in the laboratory into the clinic eventually, someday down the road.
I wouldn't say I think of myself as an artist, but I try as much as I can to be an artist, maybe in my own way.
The only art that I really did was like drawing and coloring books and simple stuff like that. Coming here, I was blown away.
Originally, Art for Health started in 1987 by a nurse who actually had cancer. And she felt that art was something that helped her to alleviate her pain and help fight depression. And so she went from unit to unit asking other patients if they wanted to do art with her. And then guest services took over. We pretty much just spend time with the patient and try to help them relax, decompress, and forget where they are. We want the patients to have fun. We want the patients to get back into the position where they used to be before they got sick.
I was very sick as a child in the hospital for quite a while, and art for me became my healing voice. So to be able to come here and give back to my patients, that's my goal.
I like the colors in that one.
Okay.
Wow, look at this one. I love all the colors.
It's just amazing.
I get a lot of release out of it. Helps me pass my days when I'm in the hospital. But yeah, I'm able to put all of my emotions into work. And it helps me heal that way. Emotionally, mentally, and even physically.
I've never really been into art that much. That's why I love the program so much, because it makes you you bring out a lot of things in yourself that you don't think you have in you.
Art for Health helps not only me, but the staff nurses, the doctors. It helps the patients deal with what they're going through, and it helps alleviate their anxiety, some of their stress. It helps distract them. So it really helps all of us.
A lot of the other programs at other hospitals, you know, they have art therapy where they actually analyze the patient, and we don't do that. We kind of just spend time with the patient and just help them to feel like a human again. I think that's the most unique part. It's just, I'm sorry, it's just my facilitators are so awesome, and the patients love them because they're here for the patients.
Every time I follow through with a patient, truly I am so moved that I'm able to do what I do, because I know that what we do can make such a tremendous difference.
It can make you feel good as a person creating a piece of artwork, something that you're proud of. Also being able to visualize your body healing and conveying that in your artwork. You know, it's mind over matter. When I started doing artwork, I kind of had an enlightenment that I was going to be better. It wasn't the end of the world.
A stroke is the brain injury that occurs when you suddenly disrupt the blood flow to the brain. The most common way is there's a blood clot that blocks off the flow so that the brain tissue doesn't get oxygen from the blood. The other way is the blood vessel can actually rupture, so there's bleeding into the brain. A stroke is a very common condition. In fact, over 750,000 people have a stroke in the United States each year, and it's the third leading cause of death and the number one cause of adult disability. The common cause of stroke in older individuals is hardening of the arteries. That can cause blood vessels to rupture for bleeding strokes, or it can make the vessel surface sticky, so a blood clot can form and block off the blood flow. One of the more common causes in young people is a tear in a blood vessel, which we call a dissection. So sometimes if there's been trauma to the neck, it can cause a tear, which can block off the blood flow. Other things that can happen in younger patients are trouble with the heart. They can have a blood clot form on an abnormal heart valve, which can break loose and go to the brain. The number one risk factor for stroke is high blood pressure. Other risk factors for stroke include diabetes, smoking, high cholesterol, heart disease, and some of the non-treatable risk factors are age, and then gender. As we said, men tend to have more strokes, particularly in their 40s, 50s, and 60s. Race, African Americans have a higher incidence of stroke than Caucasians. Preventing stroke, one of the important things to do is to identify the risk factors: high blood pressure, elevated cholesterol, smoking, lack of exercise, and try to intervene on those risk factors. Then we also use medications. In particular, we use medicines that make the blood less sticky. We often use medications to keep the cholesterol under control. What we've learned is that getting the cholesterol down very low is helpful not only for preventing heart attacks, but also is very helpful for preventing stroke. We have lots of treatment options for stroke. That's the good news. The bad news is that we have to start them very quickly after the onset of symptoms. The standard treatment that we've had for many years is a drug called TPA, which is a clot buster, which can dissolve the blood clot. And we're now using this medication up to 4.5 hours after symptom onset. The other option we have is to take the patient into what we call the cath angiogram suite, where a small tube is placed in a blood vessel in the leg. The tube goes up into the brain, and we can physically try to remove the clot with a mechanical device. We can also use clot-dissolving medicines directly into the clot with that technique. The stroke symptoms are complicated because they depend on what part of the brain has had the disrupted blood flow. If it affects the left side of the brain, typically what you'll see is weakness on the right side of the body, usually involving primarily the arm and the face, and difficulty speaking. The right side of the brain can be even more complicated because instead of the speaking problem, the patient usually has some confusion. Oftentimes when the patient is having a stroke, they may not be able to call 911, either because they don't realize it or because they're not able to talk. And that's why it's critical that people know the warning signs. The other symptoms that can occur are loss of vision. Not the total vision, but usually just vision on one half of the world. The other thing that can happen with strokes towards the back of the brain is a lack of coordination. So there's multiple different symptoms that have to be considered, but one of the things that's unique about stroke symptoms is they come on all of a sudden. So when that blood clot blocks off the flow, the patient goes from normal to having a stroke disability instantly. So there's lots going on with stroke research. One of the things that we're most excited about here at Stanford is new imaging techniques that allow us to see the stroke as it's happening. We can image the stroke and see how much of the brain has been irreversibly injured and how much is salvageable. And sometimes we'll see a patient even at 8 or 10 hours that has a considerable amount of salvageable tissue, so we can intervene with our treatments later than we might have otherwise. So being able to image the stroke as it's happening is a major advance and something that we're continuing to work on.
Loosening up, very loose.
You need to exercise no matter what age you are and what physical shape you're in. And this incorporates getting all those muscles moving, some stretching. I'm trying to get all my friends to do it.
When I first heard about this class, I thought it was going to be sort of a wimpy class, and I thought this is not going to be any big deal, but not so.
Everybody's roughly in the same place, you know. We're not a bunch of jocks. And it's very encouraging to see others our age doing this.
Sway your arms from one side to the other. What is Strong for Life? Well, Strong for Life is an exercise program for older adults who are normally not particularly active. They tend to be somewhat frail. The program is offered through Stanford Hospital. It's an ongoing program of resistance training. We use TheraBands, resistance bands, and they come in a variety of strengths. And we go through a series of 10 to 12 strengthening exercises each week. And as the participants get stronger, they change the color of their band, which increases the resistance, so they can continue to get stronger and stronger as the program goes on.
The participants in Strong for Life come from a wide range of communities. Some are disabled, and some patients don't have any medical problems. They just want to be strong and independent at home.
Okay, reverse. All the way around.
I believe Stanford Hospital feels that Strong for Life is one of the most important programs in the community. Individuals, older adults over the age of 60, will be more independent in their home. Their functional status will improve. All their daily activities are enhanced by using this muscle strengthening exercise program. And we feel that keeping individuals safe in their home, independent, is a really important thing to do.
You know, a lot of times in our culture, you know, as we get older, we just become inactive, you know, and more sedentary. Especially as people get, you know, into their 70s and 80s, they're concerned about keeping their independence. And to have a program like this where you can maintain your strength and build your strength, it's key to maintaining your independence as an older person.
I think this is the best workout program that I've come across. Everybody can do it, no matter what your limitations are.
I am so impressed with this class and how much better I feel. I feel more energetic and strong. I just feel like I'm toned from head to toe.
I thought walking the dogs would be enough exercise, but after coming here and finding out the muscles that are getting worked here, we're just so thankful to Stanford for doing this.
Just what I was going to say.